In this brief lecture, I'll talk about participation measures, quality of life measures, and a little bit about ethnographic analysis. So as your authors Murray and Clark point out, there really is a lack of participation measures that are designed to for individuals with neurogenically based cognitive and communication problems. And that's, I think, a big issue because there is obviously there are obviously specific activities that are difficult to participate in if you have communication problems. And some activities don't require much communication skills at all. Likewise with cognitive abilities, although cognitive abilities clearly are broader in their requirements in terms of lots of activities require a certain basic level of attention. And in my experience, I've never used a formal measure of participation. However, I often do measure participation informally in the form of cataloging, for example, the activities that a person did before let's say their stroke that were important to them, and maybe covering some of the more mundane basic activities of daily living that require communication, and then take an inventory of the things that the person is doing now and comparing them. And when we compare them and we see all of these activities, particularly valued activities that a patient isn't engaging in anymore, well, of course, that's an excellent place to start talking about goals of treatment. And of course, participation measures aren't necessarily about doing an activity correctly. They're just about this person is now doing this. But clearly, I think, the types of things that we do in therapy, the strategies and the skills that we train patients to do, give them more confidence to engage in and participate in different activities, social settings, etc. And I would go beyond that to say that the counseling that we do, the education, and the relationship that we build with our patients can encourage them to begin to try to engage in activities that they may be fearful of doing. And oftentimes you'll see that patients can not engage in certain social settings or certain activities when they could do it even in the light of their disability. And so there's certainly a subjective psychological component to whether people do engage in these behaviors. Now, quality of life measures are really measuring this subjective psychological component. It's really trying to measure a person's emotional, psychological, attitudinal responses to their disability, their impairments, etc. So this measures, these types of measures in particular are very subjective. And what that means is that, for example, I often have the experience that I've seen patients over time and they have not made much improvement on paper. But they're very satisfied with the treatment experience and the time that we spent together, and they're very grateful. And, when I talk to them about how therapy went in their eyes, they often talk about more feeling-oriented or subjective experiences. They talk about they're now more confident to go out into social settings, to go out to dinner with other couples. They maybe feel more at peace with the problems that they're having. They're more accepting, and they understand how best to work around them. So these quality of life issues are certainly things that I think speech pathologists think about, and I referenced a study there related to aphasia, wherein speech pathologists were interviewed and, mostly universally endorsed the importance of these kind of subjective psychological gains, these improvements in well-being related to communication and cognitive function. But in my experience, again, speech pathologists don't use formal measures. I can't think of the last report that I read from another speech pathologist that included a formal measure of quality of life. That's not giving us all license not to do it. It's the same issue as I mentioned before. There's time constraint issues. One battery that I like, the comprehensive aphasia test, has a kind of quality of life assessment built into the instrument, and it doesn't take too long to give, and so I give that, and so I am used to taking some of these kinds of measures. Some of the measures that I have started to give related to motivation touch on these issues of satisfaction. We should remember that other problems that go along with neurological damage, such as depression or neurologically based demotivated states, such as apathy, or something that many people with TBI and stroke experience, which is a kind of post-injury fatigue that can be quite profound and can take some time to kind of go away if it ever does. These do affect quality of life, and so we should just be wary that if there aren't improvements in any type of quality of life assessment that we're doing, whether it's a measurement tool or it's just simply the kind of back and forth counseling that we occasionally do with our patients to try and understand psychologically how they're doing it, that there aren't any apparent changes, but let's say there is a change, a positive change in skill, that maybe one of these other concomitant factors is playing a role. So I list some communication-related quality of life measures here. I have experience giving the burden of stroke scale because my old boss at the VA in Pittsburgh is the author of it, and one of my good friends is right now kind of the main investigator for that instrument. And when I was one of the therapists at the intensive aphasia treatment program there at the VA in Pittsburgh, the BOSS stroke scale was one of the instruments that we gave. At the time, it's quite a lengthy test, and but with length comes detail, and so there's certainly valuable information there. I know they're working on a very, very shortened but still sensitive measure that is probably due to come out soon. The assessment of living with aphasia, I have to admit I don't have experience with it, but from reading it and from knowing Ora Kagan, who is, I believe, one of the authors kind of in charge of forming this scale, and I have no doubts that it's a relatively new scale. I have no doubts that it's something worth looking at, if for no other reason than it's designed to be aphasia friendly, right? In other words, what does aphasia friendly mean in a scale? Aphasia friendly means that it's not overly dependent on language to answer or understand questions. There are lots of visual supports to help people understand the questions and to respond. We can create, not just do interviews, but create informal scales. I do that often when I keep talking about how we will talk about motivation, but for example, if I'm working with a patient on a let's say, very specific goal, their ability to hold a conversation about politics with their friends when they get together for coffee every Wednesday morning, their ability to kind of contribute to that I could write up a simple scale saying something like, how confident are you now that you can follow the conversation during these social meetings on a scale of 1 to 10. I might go, the next question might be, how confident are you that during that meeting you can contribute at least one meaningful statement in that conversation? And the next question might be, how confident are you that you could contribute 2 to 5 meaningful statements? And you get an idea. I mean, it depends on the context, right? But my point is that we shouldn't be shy about or hesitant about experimenting with these types of scales and creating them ourselves and just seeing what happens. That's how we get better at things. Again, I think I've already addressed this, as Murray and Clark does. There isn't a one-to-one relationship between how impaired somebody is and, in particular, participation and quality of life measurements, although certainly there's a gross correlation. When it comes to authentic assessment and ethnography, I find this portion of the chapter very interesting. The conversational analysis is a very specific tool designed by people in the field of applied linguistics. And so it's no small feat to come up to speed in learning how to do that. I will say that we can do something like that, particularly, let's say, if you're in a nursing home, right? And you have a patient and you want to observe how they're interacting outside of the time that you spend with them. And so sometimes when I have worked in nursing homes, particularly when they have a communal lunch area, I will just sit at the table and eat my lunch and kind of watch and see how my patient, without being too much like a spy, watch and see how they're doing. But in general, this is an area that I think holds a lot of promise, but figuring out practically how to do it is a challenge.